Hey everybody, welcome back. Today we're going to talk about knee articular cartilage defects. You're going to notice as I go through this that a lot of it's going to sound somewhat familiar compared to the ankle articular cartilage defects at the talus, if you've already listened to that one. And some of it's going to also sound kind of familiar to the total knee replacement presentation, because obviously this is at the knee. A lot of the same things that we see after this surgery, even though these patients tend to be a lot younger and more active, a lot of the same problems we see that are kind of consistent with patients after any knee surgery. So as per usual, let's start with a little anatomy review. We are looking at that articular cartilage here in the knee. And what I want you to really focus on is the white stuff on the distal femur and the back of the patella, because those are the two areas where we tend to have this cartilage damage that requires some sort of surgery. This is actually a picture of a cadaver. It's kind of a cross section through the cadaver, and you can see the white stuff on the patella. So you see the back, we have this nice, smooth, shiny white cartilage, as well as a nice layer of that cartilage on the femur. And so these are what, if you remember when we talked about cartilage in general, this is that cartilage that then will directly connect to the subchondral bone and allow for that smooth surface to allow for good knee flexion. Here's another picture. Again, this is a little bit more medial. And what I really want to point out here is that femur and that beautiful white cartilage on the femur, distal femur, and the patella. And then you'll see that the tibia looks a little bit different. This is an area where we don't have as much cartilage because we have other soft tissue. The ACL is there. It's that ligament towards the back of the picture. And then we also have the meniscus that comes through here. And the last picture is a cut through the middle of the bone. And so again, what I want to point out is that hyaline cartilage. And you can also see the meniscus in this picture, the lateral meniscus on the left, the medial meniscus on the right. And you'll see how close those joints, that joint should be, with the meniscus right cushioning in between. And we'll talk a lot about that when we talk about having meniscus surgery. You also will be able to see the ACL and the PCL in the middle of this picture. Again, this is just kind of giving you orientation. We're going to focus on femur and patella when we talk about these cartilage issues. So why does this happen? So let's just kind of review some of our anatomy, kinesiology really. So malalignment can be a big problem with some of our patients that have issues with genu varus or genu valgus. And so that ends up leading to increased pressure on the medial aspect or the lateral aspect of the femur, which can cause the cartilage to wear down. And so if you've ever, we didn't really talk about this with total knee replacements, but sometimes you can just do a partial knee replacement where the doctor just goes in and replaces either the medial or lateral side where that cartilage is wearing down. So we definitely want to be aware of alignment of things like genu varus and valgus, because those things are things we're going to have to definitely think about as we're doing our rehab. So injuries to the articular cartilage of the knee tend to happen two different ways, and so they're kind of divided in two different categories. One is what we call a focal lesion, and this is usually occurs with trauma. So trauma to possibly the meniscus, the ACL, the MCL will then lead to a tear in the cartilage. And so that's going to be a very specific tear that's usually pretty obvious on imaging. But there's also the opportunity for degenerative cartilage problems. And so I think we tend to see a little bit more of this, but this is where there might have been instability or weakness from something like a previous ACL injury or malalignment. So again, that idea of being able to make sure that the hip and the ankle foot are working correctly to help with our knee alignment, which we talk about in our classes. Very, very important that you're considering those things for non-operative treatment of cartilage damage, but also post-operative treatment. Diagnoses of this articular cartilage damage tends to occur with X-ray or MRI. So an X-ray usually just provides a visual of the fact that there is an injury, and then the MRI actually provides the staging of that injury. So again, the doctor can decide if this is appropriate for surgery or if they can do conservative care. Patients will oftentimes complain of more of a deep, dull, aching pain. It's not as localized and specific as something like a meniscus tear. So I think that's the biggest thing you want to differentiate, is this idea of meniscus is a little bit more specific. And we'll talk about that when we talk about meniscus surgeries. But what this feels like is more like a bone problem, because it's kind of deep. It's where the subchondral bone starts to get irritable, is where we start to present with symptoms. And so it's going to feel like a deep aching pain that's dull and not so obvious to point to. That pain increases with activity, and you may have locking or inconsistent range of motion measurement. So loose bodies can form just like folds can happen in the meniscus. Loose bodies can form from the cartilage in the knee as well. And so that can lead to locking. So again, it's a different reason to get locking than if there was a meniscus tear. But oftentimes if there is a loose body, then the patient will say, okay, I couldn't bend my knee for a second. And I kind of had to, shake out my leg, and then all of a sudden I could bend my knee. Those kinds of things are sometimes reported with these types of injuries, these types of wearing down. And again, if there's something floating around in there, a loose body, then oftentimes that they might report that. So conservative treatment is, again, something that we're always hoping for, that doctors will consider before surgery is necessary. And so for non-operative treatment, we're really looking to try to get full range of motion. So we want to make sure that the patient can tolerate full extension as well as flexion. So it's again, that's kind of similar to when we talk about meniscus injuries. We want to make sure that they can tolerate that, as well as obviously having good strength and normalize their joint mechanics. So that malalignment problem is very, very common. And so we're, as therapists, spending a lot of time looking at the hip as well as the ankle foot and trying to see if there's weakness or other issues that might be leading to the malalignment of the knee and therefore cartilage damage of the knee. If the patient is high irritable, then we definitely want to be considering lower impact activities. So things like cycling or swimming, to allow for decreased irritability. And as we try to increase and improve joint mechanics, we want to make sure we're doing this in a less irritable method. And so being able to incorporate something like cycling or swimming and working on alignment in an unloaded position oftentimes is much better tolerated. So it's recommended that you do that if the patient is just starting off with some treatment. Surgery is indicated if they don't do well with conservative care. So that tends to be true with all of these different post-operative things that we're going to be talking about throughout the series. Other reasons would be, again, the location and the size of the lesion. So if it's a much larger tear or hole or loose body, then they may just decide it's better to just attempt surgery. And also they want to consider the patient's activity level and goals. So patients, like I said, often could be athletes, people who really want to get back to sport. And so those kinds of people, they may say, we need to do surgery. We really want you to be out for a period of time so that you can go back and do better. So those are going to be kind of the considerations that they will make deciding on surgery. There's a couple different surgical techniques, and I'm going to show you a couple of videos related to those techniques. The first one is debridement. So if there's just a small little tear, it's just like with the meniscus, then they might just go in and clean it out. So they don't actually do anything beyond that. But most of the time they're going to do some sort of further surgery. And the first one is microfracture. And we're going to actually watch a video about microfracture here in a second. You'll see the pictures to the right there of microfracture surgery. So if you remember, we talked about this when we talked about the ankle and cartilage lesions at the ankle. Basically what they do is drill holes at different angles into the bone, into the subchondral bone, to allow for blood flow, and therefore the idea is that that's going to bring in new tissue to the area, so new cartilage to the area. So we'll watch a video again on that in just a second. The other things you'll see on this slide are what are called an OAT surgery or an OCA. And this is where they actually either take autogenous transfer, which means your own tissue, and they kind of plug it into the areas where there was injury, or they may use an allograft, which is actually a cadaverous tissue or tissue that's been grown in a lab, and actually put that directly into the injured area. So let's watch this video here on microfracture.
Articular cartilage is a firm, rubbery tissue that covers the ends of bones. It provides a smooth gliding surface for joints and acts as a cushion between bones. Cartilage can break down due to overuse or injury. This can lead to pain and swelling and problems with your joint. Your treatment will depend on the size of the defect and the judgment of your surgeon. Small incisions are made around the joint. The scope and surgical instruments will go into these incisions. The scope is inserted into the knee. Saline solution flows through a tube and into the knee to expand the joint and to improve visualization. The image is sent to a video monitor where the surgeon can see inside the joint. The damaged cartilage is removed from the joint using a specialized surgical instrument. After the damaged cartilage is removed, a drill or pick is used to make small holes in the exposed bone. Making these small holes will help heal the damaged area, thus the term drilling microfracture. After the drilling is finished, the surgical instruments are removed and the procedure is completed.
So microfractures are a pretty popular option for surgery. The other popular option is what's called an ACI. And an ACI is an autologous chondrocyte implantation. And I have a video for that one as well. What you'll see is that they actually develop a matrix and then grow cells the size of the cartilage lesion, and then they insert that into the area. So again, I think the video probably explains it a lot better than I would.
Articular cartilage is a firm, rubbery tissue that covers the ends of bones. It provides a smooth gliding surface for joints and acts as a cushion between bones. Cartilage can break down due to overuse or injury. This can lead to pain and swelling and problems using your joint. Your treatment will depend on the size and type of lesion resulting from the articular cartilage damage and the judgment of your surgeon. In certain situations, a treatment in which your own cells are implanted to repair articular cartilage damage can be performed. This procedure is known generically as a cartilage patch, or more specifically as autologous chondrocyte implantation, or ACI. Autologous means that the implanted cells come from you, and the term chondrocyte is the name for the type of cartilage cells that repair the damaged area, known as a lesion. ACI is typically reserved for patients who have sustained an injury resulting in full thickness or near full thickness damage to the articular cartilage. It is not done when cartilage damage is due to degenerative arthritis or when damage is extensive. More than one lesion can be treated with ACI in the same knee. ACI is done in two separate procedures. In the first, small incisions are made around the joint. A scope is inserted into the knee. Saline solution flows through a tube and into the knee to expand the joint and to improve visualization. The image is sent to a video monitor where the surgeon can see inside the joint. Surgical instruments go into an incision, and a small portion of healthy cartilage called a biopsy is removed from a non-weight-bearing region of the articular cartilage. After the biopsy, the surgical instruments are removed and the first procedure is completed. Cells collected from the biopsy are sent to a laboratory where they're prepared and grown in a culture for a period of several weeks. This process multiplies the number of cells to 10 million or more, which will be enough to attach to the original cartilage during the healing process and repair the lesion. The second procedure is scheduled to occur after a sufficient number of cells have been cultured. The second procedure starts with a larger incision that exposes more of the knee joint. The kneecap is moved to the side to expose the articular cartilage. The surgeon carefully removes any dead or damaged tissue from the lesion and smooths the surrounding healthy tissue. Next, a second incision is made over the shin bone, and a flap of the thick membrane that covers the bone is harvested. This flap of tissue is approximately the size of the prepared site in the articular cartilage and will serve as a patch. Next, the surgeon uses dissolving sutures to affix the patch to the previously damaged area, and the cultured cells are injected into the pocket formed beneath the patch. After the tissue is in place, the incisions are closed and the procedure is completed. During a relatively slow healing process that involves physical therapy, cartilage cells that were injected under the patch will attach to original cartilage, grow, and mature as they ultimately repair the damaged cartilage. This animation shows one of several variations for ACI. Other variations involve synthetic patches, affixing or impregnating patches with cells, or single-step techniques. Autologous cartilage implantation may also be done with other procedures that repair the meniscus or realign the knee to alleviate pressure on the new cartilage patch. Your surgeon will determine the best procedure for you based upon your lesion location, size, and mechanical alignment.
Okay, so the surgeon's going to make a choice as to the best surgery that could be performed for this type of about this type of cartilage lesion. What you'll notice is that there are some decisions that they tend to make to decide the best surgery. And so what this chart shows you is if the injury is on the femur, then the patient who might be more active, be more of an athlete, as well as a patient who has low demand, maybe they just need to walk to the grocery store, they might both get microfracture. They might both get an Oates procedure if it's a small lesion. But if the lesion is bigger than 2 to 3 centimeters, that low demand patient might get the Oates, but the higher demand patient is going to get either an OCA or maybe an ACI. And you'll see with the patella, if it's a small lesion, microfracture is going to be used for either small or large lesions of the patella. But as people become more active, then they may be choosing the Oates procedure, the OCA, or possibly even the ACI. So it's just kind of a good way to figure out sort of what they're doing. What you're going to see as we go through the time frames of rehab, microfracture is definitely a quicker time frame because we haven't introduced new cells into this tissue from outside, and so it tends to be a little bit faster than the other procedures in terms of rehab. Complications from the surgery, infection, as well as graft hypertrophy. So again, the graft doesn't take, the cells don't actually incorporate into the body, and so then they have to do another surgery if that happens. As I said, with total knee replacements, I would say infection is a much more common issue that we see in the clinic. Precautions. So it's going to be varying greatly. Your doctor is going to have different weight-bearing precautions for each of your patients because of the size of the lesion, obviously the technique that they did, and then the area of the lesion. And so usually femoral condyle lesions are going to be non-weight-bearing for a period of time, whereas patellar lesions, where they do surgery, are going to have some partial weight bearing, but the knee needs to be in full extension so that the patella is in the open packed position and is not causing increased pressure against the femur itself. So if you do get to see patients preoperatively, which as we know doesn't happen very often, you can definitely continue to try to improve their cardiovascular strength. A huge amount of our pre-op time is spent with patient education. So you're helping them sort of understand weight-bearing precautions, understand how to use crutches, and then sort of understand what their rehab process is going to look like. So for this patient, the first phase following surgery, the protected motion phase, you'll see it lasts about 4 weeks with a microfracture, whereas it lasts about 6 weeks if they're doing an OATS or an ACI procedure. During this time, we're spending a lot of time making sure that the tissue is being protected. It's really important that there's no shearing happening to that tissue. There's very little loading happening to that tissue during this first phase because, again, remember, cartilage doesn't have great blood flow. This tissue is going to take time to heal, and we need to give it the best circumstances to do that. There's definitely going to be pain and swelling, so we want to try to decrease that with modalities and possibly medication. And then our therapy is going to focus on increasing and making sure that knee extension is full. We want absolutely 0 degrees of knee extension with good quad control, or at least some quad contraction by the end of this phase. We also will start performing some knee flexion during this phase, and you'll see that our goals for range of motion are actually pretty significant, but again, we're going slowly, so don't feel like you have to get full knee range of motion by the end of this phase. You'll notice we give ourselves a couple months to get to that knee flexion range of motion. And so we need to educate our patients on that, and we need to help them understand that knee flexion is going to come slowly throughout this time period. We also want to make sure that they understand their weight-bearing status. So unfortunately, some surgeons don't give us that information very well, very easily, but we need to make sure that we're asking our surgeons, we're asking the doctors about weight-bearing, and then educating the patient on those weight-bearing instructions. So treatment is all about full knee extension. So you can do some manual therapy. You're not going to do a lot of patellar mobilizations if the surgery was on the patella, but if it was on the femur, you can definitely do patellar mobilizations, scar mobilizations, and then passive stretching to all of the posterior soft tissue. CPM is also recommended, as well as active assistive knee flexion. What's interesting about CPM is that the research tells us that they actually need to perform CPM for 6 to 8 hours per day. That's right, 6 to 8 hours. I'm guessing that there are very few places in China where they allow for that. In the US, I have seen it. It does exist. But so that 30 minutes of CPM is not going to do it. So if you can get your hands on a CPM machine and get that 6 to 8 hours, remember, we're trying to improve the synovial fluid and getting that pumping motion of the knee over and over and over again helps to bring in those nutrients and nourish that articular cartilage, as well as prevent adhesions and things like that. But remember, this is cartilage, and cartilage likes that movement. So if you can get CPM and do it 6 to 8 hours a day, or do some sort of active assistive knee flexion a significant amount of the day, that will help with the cartilage regrowth. We also can do modalities and things for edema management, and if you can also get your hands on an NMES, neuromuscular electric stimulation, just like we talked about with the total knee replacement, it can be very, very helpful in turning on those quads again after surgery. So remember, quadricep activation was really something we focused on after a knee replacement, and we really focus on it with these patients as well. We want to make sure that we're getting good quad contraction. If you can use an NMES to do that with a similar protocol to what we talked about with the knee replacement, that's great. Hopefully we'll be able to do lab with these classes, and during the lab time we can talk about and work with NMES as well. Strengthening exercises during this first phase are going to include things like straight leg raises, core training. As they're allowed to do weight bearing, you can start with very, very small squats, very small. you'll see here that our milestones to progress to the second phase do include knee flexion of 125 degrees. I'll be honest with you, I don't think you're going to get that, and that's okay. You can go slow. You'll see that that's going to be a goal in our second and third phases as well. But knee extension is very important. So we do need to get passive full knee extension as well as quadricep activation. So making sure that the quads can turn on to get that knee extension. And then another big part of this first phase is making sure that they are decreasing their pain and their swelling regularly. But having some pain, again, is pretty normal following this procedure. Second phase is going to be weeks 4 to 8 for microfracture and weeks 6 to 12 for an OATS or an ACI. So we're going to 2 months for the microfracture and 3 months for the other procedures. And our goals during this period of time is to start really increasing weight bearing and improving gait. So we want them to start getting back to functional basic activities. We also want to make sure that that quad is continuing to improve its strength and contraction, as well as endurance with knee extension. So patient education during this time is transitioning to gait without needing crutches or anything else, as well as resuming normal day-to-day activities and gait, but not sporting activities. We're not getting to sporting activities yet. So we can start doing very basic cyclical loading of the knee. So a stationary bicycle with no resistance where they can go around and around and around is going to be better than, let's say, a CPM. So this is a great time to introduce that. We also want to start doing isotonic type exercises and strengthening in that way. We're going to progress some closed chain exercises. So we're going to do some things like wall squats, leg press, step ups. And we're doing these things obviously bilateral initially, a bilateral leg press, and we're going towards unilateral by the end of this phase. And we also need to introduce our balance and proprioception activities. So you can start playing with like squats on a BOSU. You can start playing with single leg stance and doing reaching with that, or four-way hip, those kinds of balance activities. Remember, these tend to be younger people than our patients who have had a knee replacement. So we're going to start with more advanced balance activities relatively early. So by the end of the second phase, we really want them walking up to 3 kilometers, and even more than that, but really making sure that they have a regular walking program. Again, that nice cyclical movement of walking helps with cartilage loading and helps with cartilage repair. So we want full range of motion, hopefully by the end of this phase. And we also are looking at strength that is 80% or more compared to the other side. So hamstring and quad strength, as well as balance testing. So if you are doing things like a Burke balance test or a single leg stance type test, those should be 80% or better compared to their uninvolved side. And then we want to be doing cycling. So cycling should be happening for at least 30 minutes a day. Our third phase is going until 16 weeks or 4 months for microfracture, and all the way up to 26 weeks for our OATS and ACI. So we're going to 6 months for this group. And so again, this is when we're starting to do more advanced activities, just starting to think about, okay, what kind of sports are we getting back to, but we're not actually performing those sports yet. And so our goals, again, increasing muscular strength and endurance, increasing functional activities like stairs, and our strength by the end of this phase should be at 85 or 90% of the other side. So we can start doing a little more low to moderate impact activities. This is where we can start doing more intensive cycling outside, not just a stationary bike with no resistance. We can also do light hiking and things like golf. And we can start doing the elliptical, which I like for, it doesn't totally reproduce the running movement, but it's kind of similar. It's similar enough that I think the elliptical is a nice way to load a little bit more than you would with cycling. And then we're also progressing our balance and proprioception drills. So making these things a little more difficult with uneven surfaces, things like that. And we want to progress our strengthening exercises. So you'll notice we are going to start doing leg presses up to 90 degrees and bilateral squats up to 60 degrees of flexion. So we talked about our active range of motion should be full knee flexion, but we're not loading with full knee flexion. So we are not doing a deep squat. Our squats are still staying about 60 degrees because we don't want to add too much pressure to that cartilage during this phase. Okay, so we can do step-ups. Step-ups, we can go up to 20 centimeters by the end of the phase. But again, that's the end of the phase, okay? So we're working our way towards loading with more knee flexion. And so really what we're looking for at the end of this phase is full pain-free range of motion. They should not have pain any longer. Their strength, like I said, should be 85 to 90%. Their balance testing should also be at least 80%. And they really should not have any swelling or inflammation at this point. And so then by the fourth phase, this is our sport-specific training. So we're returning to the probably more high-impact activities. We're not going to go into detail about these sport-specific training, but just recognize that we're not starting that stuff until, again, the 4th month for microfracture, and this basically 6 months later, up to a year later for our OATS and ACI. So it's a long process, and we want our patients to know that from the beginning. So now you guys have sort of a time frame of what to expect for return to sport for these people. We want them to understand how cartilage heals. We've talked about that already, and so they understand what the process is going to look like for their rehab. So here's a couple of references. This is just some select references for what we used. And hope you enjoyed this one. I'm looking forward to talking to you again soon.